Hello, everyone. Thank you for attending today's webinar, Integrating Patient-Generated Health Data into the Clinical Workflow. I'm Ashley Ray Needham, and I'll be your moderator for today's discussion. We are very excited to welcome our speakers. Joining us from Validic today is Drew Schiller. Drew is the co-founder, CEO, and board director of Validic. Drew sits in a unique place in the industry. He brings the perspective of a patented technologist and experience as a successful business leader. As CEO of Validic, Drew seeks to bring unique ideas to the marketplace as a means to grow the innovation as well as the integration of technology into healthcare. He regularly writes, speaks, and advises on these issues and has been featured on several prominent platforms, including NPR, Forbes, and Fortune. Additionally, Drew serves as a board member of the Consumer Technology Association and actively contributes to the CTA's Health and Fitness Technology Standards Division. He also serves on the eHealth Initiative, Leadership Council, and Interoperability Work Group, the Clinical Trials Transformation Institute's Mobile Devices Project, and the Federal Advisory Committee's Joint API Task Force. Drew, welcome.
Thanks for having me.
We are equally pleased to welcome Dr. Martin Entwistle to today's discussion. Martin serves as the president of Aris Health Systems and has truly been a pioneer of integrating patient-generated health data into remote care programs. Martin has been an integral part of Validic's pilot demonstration with the Center for Federal Services on behalf of the Office of the National Coordinator for Health IT. His insight and foresight on the industry continues to drive research and findings that impact market perception and integration of patient-generated health data. Previously, Martin served as executive director of the David Drucker Center for Health Systems Innovation with the prestigious California healthcare provider, Palo Alto Medical Foundation. Given his vast and deep experience, it's no surprise that Martin speaks and regularly writes on the challenges, opportunities, and barriers to scaling remote monitoring programs. In his early clinical life, Martin specialized in trauma orthopedic surgery, receiving a degree from Birmingham University in the UK. Martin, welcome.
Thanks for inviting me.
Thank you. Before we get started, let's take care of a few housekeeping items. If you'd like to download the slide deck, please click the Resources List button at the bottom of your screen. This webcast is being streamed through your computer, so there's no need for a dial-in number. You can find answers to some common technical questions via the Help button at the bottom of your screen. And lastly, please note that this webinar is being recorded and will be available on demand within 24 hours of the event. So watch out for an email with the link. All right, let's begin. Today's webinar is going to kick off with a quick presentation from Drew and then Martin to set the stage for today's discussion. Drew's going to start off with a presentation on the industry occurrences paving the way for digital health and its potential impact. Martin is going to follow up with a presentation on the high-level operational as well as technical components needed to integrate patient-generated health data into clinical workflows. We'll dive deeper into both these items in a fireside chat between our two speakers, followed by an audience-driven Q&A session. So please take this time to begin submitting your questions in the Q&A box using the button at the bottom of your screen. And with that, Drew, let's kick things off to you. What's going on in healthcare?
Great. Thanks, Ashley. So I'd really like to start by showing an image from 2005. And this was the introduction ceremony, of Pope Benedict. Back in 2005, there were thousands of people in the Vatican for this event. And then I want to show you to juxtapose this 2013, and this is an image just 8 years later of the introduction ceremony of Pope Francis. And something really important happened in those 8 years. We all got a smartphone, and more importantly, a personal computer in our pocket. And clearly, as you can tell with these two images, where the first one, there was virtually no technology, and the second one, just 8 years later, with ubiquitous technology, it became something that was not only virtually ubiquitous, but also something that was very personal and very easy to use. And this is a really important factor for healthcare, because patients change the way that, or I guess consumers change the way that they approach the world. And I would argue that healthcare did not keep pace in that same amount of time with how we in healthcare engage patients as consumers. And so let's look at some other trends and how the world has changed since 2005 in healthcare specifically. So similar to the story that I just told, in 2005, smartphone penetration in the United States was about 2 to 3%. About 2 to 3% of all phones were smartphones, whereas at the end of 2016, the smartphone penetration in the United States eclipsed 80%. So virtually 4/5 of every single cell phone in the United States, it was a smartphone. Likewise, in that same amount of time, EHR adoption in the United States went from roughly about 24% all the way up to over 90%, which was a huge trend in that period of time. So every single clinician practically was digitized in that same span. And then if you look at the U.S. per capita spending between 2005 and 2016, there was about a 65% increase in the U.S. healthcare dollars per capita that we were spending per patient. And then the final trend that I want to really highlight here is to sort of take advantage of all of these trends is the U.S. dollars that are being spent in the digital health space. So this is a chart showing the number of U.S. digital health deals in the United States. And so you can see all of these trend lines converging to a point where, I mean, we're really looking at, potential digital health revolution. And I would say we have not yet quite realized that. And I want to talk through a little bit of maybe why that is. We certainly have the opportunity here. We have a smartphone in every patient's pocket. We have an EHR in front of every clinician. We have more dollars being spent in the United States, and a lot of those dollars being driven toward health IT. And we have more startups and technology companies receiving investments to capitalize on all this. So this is really what my company, Validic, is helping to take advantage of. This is what we're trying to capitalize on with Validic. So Validic is the industry's leading platform for connecting patient-generated health data from digital health apps, wearables, and in-home medical devices into the healthcare system. So we connect with over 400 devices today. These are, wearables you might find on your wrist. These are in-home FDA-listed medical devices like blood pressure monitors, glucose meters, pulse oximeters, weight scales, et cetera, as well as health apps on your phone, apps that you could use to track nutrition and other maybe a little bit more patient-reported outcome style data. And what we do is we standardize and normalize the data from all of those disparate sources and provide one simple connection into the healthcare system. So this is data that can be delivered inside of the EHR, it can be delivered inside of a patient portal, inside of an app that's meant for patient engagement. And we'll talk through a little bit more about what that could mean moving forward. But this is really how Validic is set up to take advantage of the market conditions we're seeing today. So first I want to talk a little bit about sort of why data and why this is important in healthcare. And I'd really actually like to do this by discussing a person who I'll call Michael. And Michael is a 51-year-old type 2 diabetic. To hear Michael tell his story, every single person in Michael's family who ever turned 40 got diagnosed with type 2 diabetes. So his father, his brother, his sister, even his grandmother. When Michael turned 40, he got type 2 diabetes. And, he says, look, people think I'm fat, they think I'm lazy. The reality is, that Michael actually exercises 5 days a week. He's at the Y every morning at 6 a.m. He also tracks his food. He eats really healthy. He's actually a little bit of a data geek. Michael lives in Silicon Valley, and he actually has an app on his phone, and he tracks his glucose 5 to 7 times a day. He takes it very regularly. And so Michael actually was seeing an endocrinologist to help him manage his type 2 diabetes. And he was very frustrated because what would happen is he would go in for his 3 to 6 month checkup, and his endocrinologist would do an A1C test and then try to, reactively prescribe and adjust his diabetes medication. And Michael felt like this was a very antiquated way of controlling diabetes, given two things. First is that it wasn't really working. His A1C was still a little bit out of control. And second, Michael knew that he was creating all of this data on a regular basis, but his doctor wasn't receiving it. So he took to actually downloading the data from his glucose meter app and faxing it to his endocrinologist once a month, to which his endocrinologist, I'm sure, received it and sort of discarded it immediately because he didn't understand how to read the data. He didn't fully trust the data because he didn't know the source and all this, and it wasn't something that was part of his endocrinologist program of care for Michael. Michael was really frustrated with this situation, so he actually switched providers. And with the new provider that he went to, he actually got enrolled in a program of care for type 2 diabetes that this provider had available. And what this program of care did was that it connected Michael's data, so from his glucose meter, a blood pressure monitor, a weight scale, an activity tracker, and a nutrition app. It connected all of this data into the electronic health record system where Michael's care team could actually look at the data. So the endocrinologist and the care managers were able to see the data as it came in. And at the outset, Michael was incredibly excited for this. And in fact, he said, look, if that was all that ever happened, I would have been good because I just knew that my data was going somewhere, and that's all I really wanted, is for someone else to be looking at my data, not just me. What was really interesting, though, for Michael is that about 2 weeks after being enrolled in this program, the diabetic nutritionist who was involved in this program called Michael and said, hey, first of all, things are great. You're tracking your glucose regularly, you're exercising, you're eating pretty healthy, you're doing everything the way we expect, but what's going on between 7 and 9 p.m. at night? Because your glucose levels are spiking, but we're not noticing that you're eating any food. And so they were talking about it for a little bit, and Michael said, you know what? I realized I'm a snacker. So, my kids are in college, but they live at home. At night we're sitting there watching TV, watching sports, whatever. There's a bowl of chips or a bag of popcorn. I'll just kind of grab a handful in lunch. And that was enough to throw his glucose levels off. So from that conversation, Michael actually cut out that snacking. And within 30 days, his A1C dropped by 0.5 point. It went from 8 to 7.5. And Michael said, this is the first time that I ever have felt like I can actually be in control of my disease. It's the first time he's ever had a behavioral change that led to a drop in his A1C. And it's because he had that more real-time feedback, and he was able to make that very simple behavioral change that he didn't even realize was an issue. And once he made that behavioral change, he started to see real results. And he said, I have a lifelong goal of getting to 6 of my A1C, and this is the first time I've ever actually been able to feel like I could do that. And, it's a really empowering statement for someone like Michael. And I think this is really what's important about this story is a couple of things. First is that, this is consumer-driven healthcare. I mean, Michael was not receiving the level of care that he wanted, and so he looked elsewhere. He left his care provider and found a different endocrinologist that had a care program that more suited his needs. And I think we're going to start to see that as we start to see more competition in the healthcare markets. I think we're going to see more consumers starting to really proactively look for this level of care that would drive them to a different provider. So I think that's something that's really important to highlight here. And the second thing that I want to talk about is, what did we really do differently for Michael? I mean, actually very little, right? So Michael continued to track his glucose. He continued to track his nutrition. He continued to exercise. The only real thing that we did differently was make all of that data available inside the EHR. All we did was connect up these things. And by simply integrating the data that he was already tracking, we completely changed his life and changed his perspective on how he can manage his care. And, the sad thing is this is actually kind of the bleeding edge of patient care today. But the reality is that we have been so focused on innovation in digital health, as you could see by those trend lines that I showed you earlier, that we put so much money into innovation, we've actually kind of lost focus on bringing all of this together. And now is the time that we really need to focus on integration as an industry. So we need to move from focusing on innovation to integration. And by turning our focus to integration, we can create seamless workflows for patients and providers that really start to make this technology invisible, something that's so easy to use that you don't even notice it. I call this concept invisible healthcare, and this is what we at Validic are working toward achieving every day.
Thank you, Drew, and that dovetails nicely into Martin's presentation.
Drew, thanks very much. Great introduction. Next. So I'm going to talk about some of the experience that we've had in taking patient-generated health data and using it, leveraging it into the clinical care process. You've heard in the introduction that I have been working at Sutter Health, and I'm going to relay some of the experiences really over about 10 years of tackling this problem. We're thinking a lot about the issues of patient engagement, quality of care delivery, outcomes. Thinking about this both from the point of view of an individual patient, but also from the population of patients for which any large health system is responsible. And we got very interested in the opportunities around patient-generated health data going back about 8 years. As it became possible to collect it off various devices, that data became available potentially for clinical systems. So we recognized that we needed to build quite a lot of infrastructure and organization in order to make sense of the information and turn it into something that's valuable. Now, one of the things that we thought about, we came at this really from the clinical context. I think challenges that many people face are there is a huge volume of patient-generated health data. How do I organize it? How do I manage the fire hose to turn it into something that is controllable on the clinical side? One of our insights was, let's start from the clinical view. What information is actually important to the management of a particular patient or type of patient in a context of a condition like diabetes, as Drew has described? And then we think about the range of data that's available. Some of that's going to come out of the electronic health record. It may be related to medications, lab results. Because the interesting new dimension is the data that comes from the individual in their day-to-day life, patient-generated health data off devices. But I'd encourage people to think more widely because there's an increasing range of important data about social determinants of health, mood, behaviors, etc., that's really important in determining how to get an individual to engage and where we should focus our attention. And one of our challenges historically is that that data, of course, is diverse. It's in many different systems and apps. And one of the breakthroughs for us was an ability to collect a wide range of data and have it fed to one person. Drew has described the Validic system to essentially provide a pipe with many different types of data coming through it, and that is a significant assistance in the systems that we developed. Next. We're also thinking about the challenge of, if you will, bring together two different ecosystems. Much as Drew has described, the data of interest is coming out of the consumer health ecosystem. It's about the individual in their day-to-day lives. It's coming off devices that are not necessarily historically connected into the clinical systems. On the other side, we've got the very important aspects of clinical care and driven out of electronic health records, health information exchanges, population health systems, etc. So the problem we set ourselves is to how do we really bridge that gap? How do we bring the two things together and provide context organization, if you will, create actionable intelligence from this patient-generated health data with context that is meaningful and manageable by clinical teams, including physicians, and deliver that into their workflows. Next. So just by way of background, we're also thinking about the scale of the problem from a population view, and population patients under management. And whilst organizations, using this case Sutter as an example, can be doing a really good job in terms of the outcomes being achieved in focused areas of clinical care, such as hypertension, we now need to be thinking about how do we better manage the people that are not necessarily under control. We're doing a lot of focused work. How could we improve that? And of course, what about the people that are not actively engaged with their clinical teams? And in value-based care, that's going to be increasingly important. So we've got to think holistically. How do we engage the wider population? How do we make it easy to collect information and intelligence about the whole of that population that would help us then target our delivery of care? Next. So we built a system that's designed not to replace the EHR, not to replace HIA population health systems, but to complement it. We call the system Empower. And it is designed to do the job of get that selected profiled information about an individual in the context of a program of care, understand what dimensions of that are important in terms of the clinical performance. Obvious examples are going to be the individual's BP goals, blood pressure goals, or the individual's HbA1c for diabetes, as well as lifestyle management. What's our expectation for activity or nutrition? And then use that to determine what information we need out of that massive information from patient-generated health data and pull that into the system and interpret it against the individual's care plan goals so that we can help the individual know how well they're performing, feed information back to them about that performance to drive engagement, and at the same time feed information in a focused manner to the care teams that would help them know which of their patients need help, and equally importantly, which people are doing fine, thank you, and don't need to spend the limited and valuable clinical resources outreaching to people that are actually doing okay. Next slide. So we developed a care model, and once we applied it in a certain number of narrow conditions such as hypertension, diabetes, heart failure, some areas of prevention, we always had in mind, how would you make this extensible? How do you build it up to tackle multiple conditions, for example, post-acute discharge care, etc.? Because I think most people are looking for systems that aren't a single-point solution, that when I move to the next clinical problem, I've got to acquire and deploy new technology. How do we make this work across the board? Also importantly, the workflow issues, getting the right information to the right people at the right time. And one of the things I'd like to call out is that we're very careful about what information we put in front of the physician. It's not to try and cut the physicians out of this. Of course, it's a really important role in the management process, but to try and triage activity information to different people in the care team to make best use of their skills and resources. So the workflow side of this is really important, including, as I've mentioned, how do we drive the individual, the patient themselves, to engage as strongly as possible and take greater responsibility for their care process and outcomes. And then we can apply their more limited clinical resources to the people that really need attention. And I think one other thing to call out is, and how do we make it possible to bill for this activity? Because I imagine that many people on this session are thinking about, this is all very well, but if I implement this kind of system, then I actually undermine my own revenue streams because I'm going to move care out of the clinic, out of the bricks and mortar. How do I get paid for it? And that's a really important aspect. How do we make these kind of systems tap into payment models, revenue streams, telemedicine, chronic care management, et cetera, that can make revenue generation a part of this process? Next slide. So last in my introduction, people obviously and reasonably ask about outcomes. And here's just a snapshot of some information. This is from a study in 149 patients with hypertension put through the process I've just described. And we were excited to find outcomes that were positive in this. So whilst all the individuals going in were uncontrolled, under usual care, so they were actively being managed by the clinical team, and we added in this dimension of care management, and we got 54% of people under control at 6 months. Slightly higher percentage than that, around 64%, when assessed by their home BP measurements. Now, I'm not going to sit here and pretend that that is compelling evidence about outcomes. It was a reasonably short study and it's small patient numbers. But I think it does illustrate that if we build systems that bring multiple dimensions together, it isn't just about connecting patient-generated data to the clinical record and hoping that that's going to make a difference. It's thinking about driving actionable intelligence, delivering the right information to the right people at the right time, building feedback loops, building in workflows. I think all of those dimensions are important. And this gives you some indication that if you do that and create systems of that type, then there is some evidence that this will drive better outcomes and better process. Ashley, thanks.
Thank you, Martin, and thank you, Drew, for sharing that invaluable insight. And at this time, we just ask that everyone continue to submit questions via the button at the bottom of your screen, and we'll jump into that fireside chat. You can also follow along with the conversation on Twitter at Validic, V-A-L-I-D-I-C. Drew, let's throw the first question to you. And Martin, please join in with your thoughts and perspectives. What do you consider the organizational challenges associated with integrating patient-generated health data into remote care programs?
Yeah, absolutely. I mean, they're varied. I think Martin really did a good job at high level addressing some of the challenges and his thought process for getting around them. One of the things that I often hear is, clinicians and folks within the administration of health systems will say, yeah, but what do we do with all of this data? and my response is always, if you have clinicians who feel overwhelmed by the volume of data that are coming from patients in a PGHD program, then you're doing it wrong. The fact of the matter is that what clinicians do not need is more data. What clinicians need is actually more information. And Martin mentioned having the right data present the right time in the right way, and I think that's really important. And the way I think about this is that what we're really doing is bridging two different data paradigms. So the EHR and how clinicians typically provide care is a very episodic data model. So these are all, everything inside the EHR is focused on an encounter, right? A patient encounter. Patient-generated health data is continuous information. We're talking about multiple readings a day. In some instances, many hundreds of readings a day, depending on the resolution of data and the type of device that you're using to monitor a patient. And it's just impractical to expect for all of that data to make it into the EHR in a meaningful way, given that you're taking continuous data and trying to map that to episodic data. So the way that I think about this is really, how can you turn the data that's coming from the patient into information that's something the doctor can recognize? So one example of that would be, maybe there's a threshold where in an instance of hypertension, like Martin was talking about, if a patient has, 2 readings in a row that are above a certain threshold, maybe that's concerning and something where a care manager should be alerted to reach out to that patient and make sure that everything's going okay, whether their blood pressure medicine is working properly, making sure they're taking their blood pressure medicine, making sure they're doing the other behavioral changes they need to be, see if they need to come in for a visit to do more of a 360 review. Another really important thing there is, maybe the absence of data could be really important. So maybe a hypertensive patient hasn't taken a reading in the last 48 or 72 hours. Well, that could be really important information too, because it's indicative that they're off of their care plan. So likewise, using the absence of data to actually send an alert to a care manager and saying, hey, this is something that you should probably reach out to this individual patient on to make sure that everything is going okay. So turning the data into information that someone can take action on is really important. The second thing that I think is really important in this is that there are a lot of cost pressures today inside of health systems that make developing a robust patient-generated health data system a little bit complex, right? So you have the CIO and the CTO's office really looking at limiting vendor relationships and reducing the amount of technology infrastructure and staff they have. But there are more and more technology components coming out every single day, solutions for diabetes or solutions for hypertension or solutions for, readmissions or heart failure. And as each of these vendors are sort of coming into the healthcare system, it becomes difficult to not only manage these multiple vendor relationships with a decreased budget, but then also being able to integrate all of these disparate complex data sets and varied workflows into the EHR in a way that's going to be meaningful and consistent across the board. And I think that that's a really important challenge that needs to be addressed. Something that I'm certainly thinking a lot about at Validic is, how is it possible to work with a decreased budget, but still manage the complexity of a patient-generated health data environment in a way that can add a ton of value to patients without substantially increasing costs on the health system side.
If I can just add a few points. I think one of the big organizational concerns is about inundation overload, particularly of physicians, and that's very reasonable. On the one hand, we've got this pent-up energy for individuals, consumers, patients to be providing their data. With no shortage of that. We've got potentially an appetite to receive it because people know that it could help them, but the risk of being inundated. And whilst I think the future will have us just accept and use a wide range of patient-generated health data, we have to get off the ground somehow. And I've already touched on, one way to do that is by limiting the range of data that we accept to be used in this kind of clinical setting. And another feature is maybe to only enroll certain patients, so the concept of programs of care, and allow the physician to determine which patients should be in those programs, and therefore which patients they need to pay attention to. So they start as they would enroll a patient to any other program, cardiac rehab, etc. So there's an explicit recognition that the individual is going to be contributing data, and they've, in principle, accepted that they will be receiving and using that and responding to it. That's one idea on how to turn that into a more manageable process. Some of the other challenges, I think, are about where we focus this information, which individuals in the broader care team beyond physicians are also going to have responsibility. And I think it does open up a lot of opportunities for other people in the care team, nurse care managers, RNs, other support staff, coaches, etc., to be part of the mix of taking responsibility for patient care. But that also has to be thought through. Which people are responsible at which time? Are we going to involve call center work, remote patient care? So thinking through and describing a workflow, hopefully leveraging and building off the kind of workflows that you already have in place, and being explicit as to how to do that. Then the step beyond that is then people need to understand their responsibility for managing an individual that is not in front of them. So there's also workforce training, education, standard work is part of this process to make it safe and effective.
Thank you. And sort of building off your comments about a team-based approach, what are some of the other operational and also bridging into technical components that are needed to support the use of PGHD in these remote clinical care programs? Martin, why don't you kick us off?
Yes, as we've outlined, one of the challenges is the volume of data, significant. And I think a question for people to ask is, does it make the most sense to connect all of that data into the EHR, or do we create some intermediary step, a data lake, and collect PGHD in that, and then pull and interpret the data we need as part of patient care and connect that to the electronic health record? I think that's an area well worth debating, because if the data is directly connected to the EHR, it has all the implications that we've touched on as driving concerns. Now it's in the EHR, and we've got responsibility for it. I think another technical issue is think about which devices we're going to allow to connect as part of our approved system. We've had experience with some of the devices, possibly coming more from the consumer world, that have got clinical capabilities, such as BP cups, that don't necessarily provide the level of accuracy that we need for clinical management. So a thought is to think about constraining the range of devices that you're allowed to connect. We've talked about interpretation. Personally, I'm convinced that it's important to find some ways to interpret the data that we receive and think technically about how to do that. Is that going to be done within the existing clinical systems that you have deployed, or are you going to adopt some kind of specialist system to do that job? So there's actually just a few ideas that I think are important.
Yeah, absolutely. Thanks, Martin. On that last point you just made about the devices, the FDA recently came out with some thoughts around how they're going to start to potentially help to provide guidelines for consumer health apps and devices that are sort of fall under a deregulated side of the FDA today that they consider more wellness-focused devices. And so hopefully we'll start to see a little bit more rigor around that side of the world. And additionally, as Ashley mentioned at the top, I'm on the board of the Consumer Technology Association Health and Fitness Technology Division, and that group has a corresponding standards body. And we've recently created a standards group that's working on developing or looking to develop potentially a certification for apps in the consumer space to help to enable them to really self-certify that they meet a certain threshold of rigor, so that there could be some confidence if there's a certain seal of approval on that app or device in terms of the veracity of the data, et cetera. So I think that's really important. And the other piece you mentioned I think is really critical in this, which is implementing a program of care. And that's something, Martin, that you've really helped me realize and helped open my eyes to, which is that it's so important for a patient when they're going into a new system, whether it's to manage a chronic condition like hypertension, or whether it's to manage an acute condition such as post-op from joint replacement. But as part of the technical components of that, so that's an operational component. As part of the technical components of that, I've also seen that, clinicians are exceedingly dedicated to their patients. And oftentimes, there's actually, the health system is actually doing a little bit of a disservice to the clinician in terms of how they want to care for their patients. So one example I'll give you is there's an endocrinologist who I spoke with who manages type 1 diabetics, and his health system uses Epic. And so what he likes to do is prescribe Dexcom continuous glucose meters to his patients, but the Dexcom data does not flow into his health system's Epic. And so what he does is there's like a sharing function inside of Dexcom. And so he actually has his patients share their credentials with him. And then on evenings and weekends, he goes home, he pulls up his personal laptop and logs into Dexcom and logs into each of their accounts and kind of looks through it there, and then pulls up his work laptop and opens up Epic, and then reads his personal laptop, reads off the screen, types patient notes into the Epic chart, and that's how he manages his type 1 diabetic population. It's completely not ideal, and it's not something he's even able to bill for, but that's the best way for him to deliver care. And so I think that as we're talking through the operational and technical components, I think it's really important to really look at what clinicians are trying to do and how they're looking to deliver care for their patients, and try to ladder up a solution that will enable them to provide the best care they can for their patients. And, I think that right now today we've kind of gotten a little bit misaligned in terms of how the clinicians want to care for patients, especially using PGHD, and how health systems are looking at running their operations with regards to this data. So I think there's a disconnect there that I'd like to see bridged.
Thank you, Drew. An important part of providing that care is engaging patients, and that sort of takes us into the next question. How do you engage patients in these remote care programs? Drew, do you want to kick us off?
Yeah, sure. I think Martin will have a lot to add here, given his experience as a clinician. I will say that where I've seen programs be most effective is when you work to meet the patient where they are, and you're not trying to implement an entire lifestyle change all at once with a patient. So one really easy example, and this is probably overly simplified, but the example where I shared with Michael, the type 2 diabetic at the top of this webinar, who was already, tracking his glucose, tracking his weight, tracking his nutrition, et cetera, and all we did was provide a simple mechanism for that data to be delivered into the healthcare system. I mean, Michael probably had to make a couple of changes. He might have had to change an app. But in terms of functionally the work that he was doing to get that data into the healthcare system, he didn't actually have to do much, right? So what was not done is we didn't say, hey, Michael, you have to completely change the way you manage your diabetes. Instead, we said, hey, here's how we're going to ask you to do this and how we're going to ask you to get the data in. And it was a very simple process for him because he already had the process down on his side. Now, that may mean for some patients, and this might get back to what Martin was saying about maybe you enroll certain select patients into a program, but certain patients, this might be a complete lifestyle change. And so maybe you don't start by tracking everything under the sun for them. Maybe you just start by tracking glucose, or maybe you just start by tracking their weight on a regular basis, and you start to develop those habits and the behavior change. I think that's really important. And then the last piece I'll mention is the behavioral dynamic of this, which is that a lot of these conditions that we're talking about, diabetes, hypertension, heart failure, are oftentimes comorbidic with depression or other behavioral conditions, and those conditions really exacerbate the non-compliance with a treatment protocol. And I think we often talk about data and hard numbers and taking glucose readings or taking blood pressure readings, and we talk about things from that perspective. But what we oftentimes don't talk a lot about are what the patient, him or herself, is actually experiencing in this process, and maybe helping work with them to get over that, whether it's through a clinical psychologist as part of the program, or a social worker, or someone who can help them manage some of the other details about this program, and as well, along with their anxiety and depression and concerns about what it means to actually be living with this condition. So I think that's all important and encompassing in engaging patients in these remote care programs.
Some things to add to that. The experience that we've had has been fairly compelling, that the engagement level is much greater if the invite to participate in the program comes from the individual's personal physician. And it's framed as being part of the plan of care for you. Where we've attempted to more generally recruit patients into programs that have been less successful. So that personal touch coming from a physician is really important. Next thing is we do need to make it as easy as possible to get up and running, and Drew's just touched on that. So if there are too many steps, or the steps that kind of have bugs in it, then that will put a lot of people off. So even though they may start the engagement process, they don't really get into the program. So reliability and simplicity, is important. An issue we've not touched on is it BYOD, bring your own device, or do we provide devices? Now, if you provide devices, then probably the engagement level will go up. Although if you just provide them, do people have skin in the game? The questions about that. On the other hand, the economics are such that if you're providing devices and covering the cost, it's a whole different ballgame than BYOD. But just factor in that that's an important dimension as to whether people will engage or not. And I think my last comment on this, which is also important, is we need to recognize that this type of program doesn't suit everyone's persona or style. And that if we're smart, we will have a range of different interventions for different types of people. I think we can get a significant number of people at this point in time to engage in this type of program. But I don't think we should regard it as failure if we don't get everybody, because it just doesn't suit all people. And in that, we also have to be careful not to make assumptions. I still hear comments about, well, older people won't necessarily engage because it requires technology. That is not always the case. We've got examples of people who are technical advocates, geeks, if you will, that actually don't like this kind of program. And we've got people who really have got very little experience of technology that take to it extremely strongly. In terms of ongoing engagement, one of the other learning points has been we have to show that you contributing your data actually matters to us on the clinical delivery side. We have to pay attention to it. We have to show that it matters to us, because if we don't do that, then people will go off the boil pretty fast. Why would I continue to contribute my data if it's not being paid attention to on the other side? So there are just some insights and learnings that we've had as to how to get people to engage and how to try and drive sustained engagement.
Thank you, Martin, and thank you, Drew. Okay, now it's time for your questions. Thank you to everyone who has submitted so far. For everyone else, there's still time to submit your questions using the Q&A button at the bottom of your screen, and we have a lot to get to. For the first question we have, what kind of results have you seen from these types of programs? Drew, why don't you kick us off?
Sure, yeah, absolutely. I mean, we've seen a variety of really positive results. One that I'll highlight just because it has a really striking ROI number is one of our partners is a company called I Get Better in the Northeast, and they were working with a hospital there around readmissions for heart failure. And what they did was they connected blood pressure monitors and weight scales to proactively monitor patients who are post-op from heart failure to prevent a readmission. And in the first trial out of the gates, they enrolled 31 patients into this program. Now, typically speaking, this hospital, Brockton Hospital, they would have expected about 28% of those patients to be readmitted. So about eight of the 31 patients to be readmitted. And in that study, actually, 0 patients were readmitted. And the reason is because what happened was that the patients were being proactively monitored with their blood pressure and weight. If there were any concerns, somebody from I Get Better called them and said, hey, what's going on? Do you need a checkup? Is everything going okay? And, in a few instances, patients were brought in for a quick checkup and a quick adjustment as opposed to having a relapse and a readmission. And so that was immediately, for Brockton, that particular readmission would have cost them, I believe it was $27,000 each. And so that was an immediate cost savings to Brockton of $216,000 for implementing this program. So we're starting to see some really interesting programs out there that are able to directly add to the bottom line by simply tapping into existing cost mechanisms within healthcare and preventing readmissions. The other thing that we've seen is where you can actually use this data to drive patients who are being monitored toward an inpatient visit as opposed to a visit that might typically fall into the emergency department. So, for example, if you are monitoring patients who are maybe comorbidic with diabetes and hypertension, and something is out of whack, like their blood pressure is really high or their glucose readings are really high or really low, you can proactively reach out to that person and say, hey, please come in for an appointment, rather than letting that situation exacerbate itself and then having them flow through the emergency department and have a much more costly interaction with the healthcare system. So that's another way where we're starting to see things really happen well with patient-generated health data.
A few thoughts on my side experience. I mentioned when I was talking earlier about some of the clinical outcomes, so some evidence there of positive impact. I think it's important to also focus on process. And experience has been from patients that those that engage in this, and remember my caveat that it's not a learning style that suits everybody, but those that engage find it valuable. They definitely are supported in learning new approaches to managing their behaviors, whether it's being more active or thinking about nutrition as part of their broader clinical management. And we've generally received positive feedback in terms of people then understanding the impact of certain things that they do on their clinical condition. And Drew described that with his one story. And that isn't an isolated experience. That people then begin to make feedback loops between things they do and their clinical performance. And that's really encouraging because that's positive experience. On the clinical side, you would understand that we face quite a lot of skepticism from physicians and clinical teams as to would this help. But having worked hard on trying to get the right information for the clinical workflow, the experience when we get that right is that this is extremely helpful. So for example, if physicians, before, say, an office visit, can see the performance of an individual against their clinical goals over the last 3 months, 6 months. So when the patient is in front of them, they can have a different quality of dialogue with that information in front of them than if they've got to spend time really eliciting some kind of similar information, but without the same level of intelligence around it as to what's really been going on. So, well organized, there are positive experiences and impacts both for the clinical care team and on the patient side.
Thank you. And Martin, you touched briefly on this, but since we've received a couple of questions, it's worth diving in a little deeper. Do you see an age gap difference in people embracing this technology, elderly patients versus young adults or quote-unquote millennials?
Yes, I'd have to say that is true, but it isn't sort of binary that certain ages will or won't engage. I think it's important to recognize the type of experience that, say, a millennial is looking for in terms of the way information is presented, the focus, etc., that they're after is going to be different, say, than an older person who may be more willing to receive information that they've got to, education, be more accurate, they've got to work their way through. In any generation, there are going to be some people that will engage with the technology and some that won't. That said, I do think we've got to constantly focus on the way that we're putting our systems together, user interfaces, user experience, workflows, and also educate people as to how they can best use the technology for them and their particular learning style. I'd also say in passing that I think some of the new capabilities that people are exploring around AI, I'm thinking about voice bots, etc., and the way that they can present information as part of these broader systems, I think is going to be very interesting. So, as Drew mentioned, we're in a time of very rapid advancing technology with new opportunities coming along that I think are going to help address some of these age-based challenges that we might currently face.
Yeah, I think that's a really great point, Martin. One thing that I'm struck by is on this question about aging is that so I think that there's a couple of different ways about thinking about technology, and I'm going to again go back to what I said at the beginning, the concept of invisible healthcare, and making this something where the technology is relatively invisible for the patient as well as for the provider and the care team. And so one example that I'll give is my grandmother, who unfortunately passed away a couple of years ago after being discharged from the hospital for being treated with COPD. Now, I don't know if everyone knows this, but COPD is actually very deadly for patients who are over 65 after they've been admitted to the hospital for treatment. So there was a study in Ontario that found that for patients who are 65 and older after being discharged for treatment with COPD, I believe the number is 25% of them died, or sorry, it was 8% of them died within the first 30 days, and then 25% of them died within the first year. So it's a very, 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 very deadly condition. And my grandma, unfortunately, was one of those 8%. She died 2 days after being discharged. And the way that she passed, she was actually, and I've heard this story, unfortunately, quite a number of times from other people as I'm telling this. There's a number of strikingly similar stories. So she was in her assisted living facility, and they found her slumped over her nightstand reaching for her call button. Like, she just couldn't get there in time. Like, there's a problem with her cables or something like that in her oxygen machine. And, I'm thinking to myself, after obviously the initial shock and sadness, I was thinking as a technologist, why is there a call button on the wall? I mean, the side mirrors on my 2008 Volvo have a camera in it that lets me know if someone is in my blind spot. Like, why isn't there, like a movement camera in her room that's just noticing, like, hey, Betty doesn't typically move like this at 2 in the morning. Maybe we should just have someone check on her and make sure everything's okay, right? Or why isn't there, like a device in her room where she could, even something as simple as an Amazon Echo, where she could say, Alexa, I need help, right? And have someone come into her room. I mean, there's so many simple pieces of technology that could be there that could prevent that type of situation. And so I think that, we in healthcare, we oftentimes fixate on, the phone or the new device or the wearable or this. But I think that there's a lot that we can do with actually existing technology in the world that we just simply don't apply to healthcare right now. And so we have a long way to go to build that invisible healthcare system. But again, the technology is there for us to do it. We just have to kind of think differently about how we apply it in order to really reach more patients.
That's a great point. And Drew, in terms of the technology that we can use to apply to programs of care today, what are the easiest disease states to launch a remote clinical program with?
Wow. I'll answer that in 2 different ways. So first, I'm not a clinician. I will say that, we have seen a number of interesting programs being developed around hypertension and diabetes. And I think the reason is because, those affect so many people in the United States. There are actually some pretty interesting low-hanging fruit opportunities, though, that I see. One is, for example, coagulation clinics. So, for patients who are using a coagulation meter, that's typically a very expensive patient and somebody who you really want to make sure that you're monitoring closely. But the current paradigm is for that patient to use the coagulation meter in their home and for someone to potentially call once a week and get the data readings from them. Well, it would be much simpler if the data from that coagulation meter just went directly into the EHR, and so there's, the 2 or 3 readings that are taken every day are going directly into a place where clinicians and care managers can look at that information and call proactively if there's a problem, and also monitor that patient to find out if maybe if they're not taking their readings as regularly as they should be, call and reach out proactively to make sure that they are. So I think that, that's an instance where, we're talking about 1 reading. It's a relatively small patient size. There's already a paradigm inside of most health systems, especially ones that do transplants, et cetera, that have this patient population. And in most health systems that I've talked to who have coagulation clinics, their panel sizes that they're able to actually monitor actively are much smaller than the total number of patients who could be eligible for that program. So I think by turning the coagulation meters into connected patient-generated health data devices, that's actually an example where you could increase the panel size, potentially increase the volume of revenue in addition to the volume of patients, and hopefully provide a much more favorable experience for the patient themselves. But I think there's a number of opportunities like that are, sort of just under the radar of sort of where most folks are spending their time in healthcare, but I think are really ripe for opportunity with patient-generated health data.
Martin, do you want to take just a moment to close us out with a response?
Yeah, I just add to that. Whilst there are many broad, exciting areas, I think the question is a good one: how do we get off the ground? And I'd encourage people to look at the areas where information from the home environment that isn't that complex in its dimensions would give us significant insight into an intervention that makes a difference. So heart failure is a very good example that if we measure weight accurately at home, it can give us insight and make a significant difference to that patient. Not too difficult to do. Similarly, some of the post-acute, post-surgery discharge, not dissimilar to what Drew's just describing. So a few dimensions of data that are easily gathered make a huge difference as to whether we know that individual is doing okay and help us intervene. So whilst the, areas like diabetes are exciting, huge potential, and some of the others are maybe simpler to get off the ground.
Thank you. And a big thank you to everyone that attended today's webinar. A special thank you to our speakers, Drew Schiller of Alytic and Martin Inkswessel of Aris Health Systems for participating. We will follow up with each of you to deliver a white paper featuring interviews with Martin and Drew, answering many of the questions we were not able to get to today, including standards, reimbursement, and EHR integration. So look out for an email from Alytic with that white paper. Thank you again for joining us, and we hope to see you at future events.